the men in the room stand up? Men, stand up. You know, you guys have to find this just as important as we do. And I'll talk a little bit about, you know, the statistics and all of that. But this was a really important panel for me. We're amongst friends, and and Dr. Hashim was like, I didn't mean to put Celina on the spot. He's my interventional cardiologist. He's the one that diagnosed me. So give a round of applause for my doctor that diagnosed me. This is gonna be fun. I'm calling it a fireside chat because we want to get cozy. This is a conversation. It's not an interview. It's not a panel. And, you know, we have some really amazing, passionate people up here. And they're here to make our lives better, women's lives better. But let's be clear that this fight has been championed by women, right, for much of it, most of it. And we would be missing, I think, a pretty crucial, a really significant community if we didn't think about allyship and what that looks like with men. Wait, I need my glasses. I don't know why I'm trying to read this without my glasses. What the heck? So we also know that 85% of cardiologists are men. So, you know, somebody mentioned earlier, I think it was Claire from the Menopause Foundation, you know, she said, we would be doing people a disservice if we said, if you don't like your, you know, doctor, go find another one, right? Because for many people, they don't have options. It's the same for women cardiologists, right? If we say, like, go find yourself a female cardiologist, that's also setting people up for failure. So we've got to have this conversation with the men in the room to help us figure out how to get more men to champion this conversation. According to a 2022 systematic review published in the ACC's Cardiovascular Disease in Women Committee, published in February 22, in their journal, female physicians have better patient outcomes compared to with male peers. We heard Caroline talk about this earlier. While female patients are less likely to receive guideline-recommended care when treated by a male physician, and that's according to the systematic review. So in the spirit of engaging in a meaningful discussion to move the needle, I'm very excited to be having this conversation today. If I can have each of the panelists introduce yourselves and talk a little bit about why you are championing the cause of women's heart health. Who wants to start? Yeah.
Okay.
Yeah.
So like I said, my name is Shashank Desai. I'm a heart failure transplant cardiologist by training. And our space has several stories we can talk a little bit about. And what I would say is that I don't think that this is any other subspecialty creation than interventional cardiology, than lipids, now cardio-oncology, and I can go on and on about all of the different subspecialties. I think we start realizing that the disease presentation is different, the data we have is different, the treatments are because of not only patient-specific genomics, but we're really talking about men and women having inherent cardiovascular differences. And I think we have done a horrible job in medical training actually training individuals for this. So I was tasked as our Heart and Vascular Service Line leadership several years ago to start a women's cardiology division at Inova. And I can expand upon all of the trials and tribulations I went through. But we recruited a famous cardiologist named Gorre. That was a 4-year...
My cardiologist, by the way, FYI.
That was a 4-year recruit. I had to court her longer than I did my wife. But the journey was well worth it. And the journey of bringing in a women's cardiology expert, be her female or not. But the fact is that the rest of Inova cardiology has transformed because of her presence alone. And I'm also happy to say that we started a women's cardiology fellowship. It is a subspecialty training, no different than the two of us. There is specialty knowledge there, and our first women's cardiology fellow is a male. And so the idea is that this is a subspecialty, and I do think we have to invest in it as such.
Fantastic.
Perfect. So again, Hayder, Hashim, work at the Washington Hospital Center. I totally agree with Dr. Desai, to be honest with you. The area of interest as I was finishing up the story in microvascular, and obviously I needed support, and the support I found from physicians that Celina knows. They're all my female colleagues. Barbara Strichai, Estelle Jean, Shay Princewell, Christy Kaiser. I could go on down the list, and all those women, they influenced me in a way that they were looking for answer. They are frustrated themselves, and I just follow suit. And now there is, with this microvascular, most of my referrings are actually coming from men physicians, because now everyone is aware why those patients are there. They are not making up stories. They come in with complaints. So now it's truly leading by an example of women, and cardiology women, kind of brought the needle from all the men who actually trained in different eras, different generation. They're now thinking about the disease, thinking about the women, cardiology women's center and the hospital center, and we're moving things forward. That's one of the things. I didn't know you have a fellowship. I'll send you some candidate. Well, I'm serious. Like one of my fellows is asking me. She wants to understand cardiology in pregnancy, which is very unique.
Thank you. So Neil is, I'm just going to say it now, don't ask him for, to do an EKG on you. He's not a cardiologist.
Correct.
But he's just as passionate about this work. So Neil, over to you.
So firstly, my name is Neil Johnson. I'm from Ireland. And Celina, I really want to thank you for the invitation to be here. This has been a most inspiring morning. And my background is in psychology, and my journey into patient advocacy began 33 years ago, when my job involved trying to address in our small country a geographical disparity. Literally in our small country, whether you lived in the east or the west depended on what type of cardiovascular care you got, and had to do with the fact that the concentration of population was in one city and resources were attached to that. The good news is that over those years, that geographic imbalance has been addressed. And then probably 8 or 9 years ago, I started to get involved in developing what is now the Global Heart Hub, an international alliance of heart patient organizations. Thank you. And there was a convergence of a number of factors. One, that was my first interaction with WomenHeart, Susan Campbell, and now more recently yourself. The fact that I was looking at my own daughters growing older, as in growing up, and my mother's ill health. And I saw at first hand her journey through heart failure, from delayed misdiagnosis and just appalling management to an appalling, rapidly deteriorating quality of life, all of which I put down to the fact that she was a woman. And this has inspired me to, in a Global Heart Hub context, make this issue something that we need to work together at. Not just here in the US, obviously, but internationally.
Thank you, Neil. Thank you. So I want to start the questions around what can happen in the clinical setting. So I'll ask the doctors on the panel, what do you think the barriers are to getting more male clinicians involved in really taking seriously the sort of the not just the unique presentation of heart disease in women, but sort of the unique needs of care for women with heart disease?
I think it's a systemic problem. It started with training. We go back to the data, when we collected data, when we were students, when I was a student, I'm going to speak to myself, the data available, the textbook that we read, it's always 65%, 70% of the cohort is men. It's a systemic issue that grew up. We feel comfortable. Human species is, we're a species of habits. I'm very comfortable accessing the radial artery. Dr. Desai is very comfortable adjusting Entresto, a medication I'm not comfortable with. He is. Same thing. I'm more comfortable giving you blood thinners than he is. We're nature. We live in habits. So we grew up in medicine. This is what we have available. This is what we taught. This is, I believe, the number one barrier is the fact that we don't want to tackle new challenges. That's what drives us as I don't want to brag and say thought leaders, but that's why he came to Inova. That's why he was recruited to Inova, because he brought a vision that let's not accept the status quo. I learned this in Harvard. I learned this in Mass General. I went to NYU. I trained at Montefiore. But now I need to take this, to push the envelope a bit more and go to an uncomfortable zone. My uncomfortable zone is, I told you, I just didn't like why women come in. I could tell you, you don't need this, but I didn't tell you what you have. Like, how is this acceptable? I don't accept it for myself. I don't accept to go to a doctor who will tell me, you might have cancer, go get chemotherapy, that will make you lose your hair. I'm going to live as like, is he nuts? What are you talking about? I'm not going to do this. I need a diagnosis. Patients seek diagnoses. So for that reason, we just need to push the envelope more, and the number one barrier is what we're comfortable with.
Before you go, Dr. Desai, I just wanted to share my quick 30-second story.
Okay.
Because after 2 years of ER visits, 9 or 10 ER visits with chest pain over and over and over again with no diagnosis, I landed in the cath lab, Dr. Hashim's cath lab, on my birthday 2 years ago. Remember?
I do.
And and I was still groggy, and I remember this so clearly and vividly. He says to me, "Happy birthday, Celina, you're not crazy." That's how he gave me my diagnosis. And I know lots of you can understand what I'm talking about. So anyway, I've been lucky. I've been really lucky to have amazing people treat me.
Let me give you a story of why I think we have to unlearn. And so here's the problem. And I would say that, most physicians don't like to have continuing education because it's a lot of work. But the fact is, the world changes, right? And like you said, everything from 15 years ago is obsolete. So there is a core tenet of heart failure. On the heart echo, it's called ejection fraction. It's how much your heart squeezes. And everything we've learned, and everything from FDA reimbursement for devices and how these devices were all based on ejection fraction. And the one thing we failed to recognize, because of all of our studies as were brought up, were white men and not female, not minorities, and that we assumed that that's what was true for everybody that was not included in these cohorts. And that ejection fraction of 35% diagnosed heart failure, and the core of every internist cardiologist in this country says this ejection fraction must be heart failure. But anything above it, they must be fine. And what has been realized over the last 10 years, you bring up the idea of what has been new, the fact is we realize that women's heart failure tends to be at a much higher ejection fraction. That ejection fraction does not belie heart failure, but yet we have learned for this many decades that if your ejection fraction is low, so we have been missing women. The incidence for women heart failure is lower than men until menopause, and then it catches up and it exceeds. But all of those things have been missed. So if we look back over the last 30 years and we say outcomes, women die more frequently of heart failure, of heart attacks, of heart disease. They get less access to things like heart transplant because they fail to be recognized 3 steps before the transplant center. And so we have to unlearn that ejection fraction does not mean heart failure. And it is such a core tenet, and it'll take the same number of years to unlearn. And so that's part of the reason why we need women's heart centers.
Thank you. Over to you, Neil. Neil and I have had many conversations, Neil and I have had many conversations in the last couple of years, I would say, about women's heart health. So I'd love for you to share some observations that you've made in the last year. You've used the word outraged with me. So what are some things that you've observed in the last year that make you outraged about this disparity affecting half of the world's population?
So speaking about outrage, as I was listening to the McKinsey data this morning, I was thinking, if that presentation was on male health to a male audience, there would have been a riot in the room. okay? And I think that the underlying issue here, and we need to call a spade, is that cardiovascular medicine, medicine in general, has been dominated by millennia of patriarchy. This is the problem. This is the underlying problem. And in December, I was at a congress here, cardiovascular clinical trials research. And I went to that meeting because I was interested to know, could we gain some insights as how we might increase the participation of women in clinical trials? But I came out of that, to use your term, enraged by the data that was being presented, which basically showed that the problem is actually systemic. So systemic that it's shocking, in the sense that women are grossly underrepresented in cardiovascular medicine, first of all, and they're also grossly underrepresented in clinical trial leadership. And actually, I'm not misquoted, I was looking at, or they shared with us, for example, in some clinical trial leadership, and I think it may well be primarily in the area of heart failure, actually, between 2014 and 2018, 42% of clinical research had no female investigators. 56% had no female physician in the steering committees or clinical research. When you look at authorship of research and the disparity between men and women, it's like a tenfold disparity between men and women. When you look at, for example, the number of women who are lead authors, senior authors, corresponding authors, the numbers aren't just minuscule. The gap is like, it's eye-opening, jaw-dropping. When you look at the number of women in decision-making around research grant funding, again, minuscule. So the problem here is that men have been dominating this landscape, and the reality is, if you don't do the research properly, you're going to have all the problems that you guys are describing here, because you don't understand what you're seeing. And you don't understand it because you don't have the data. So this is a systemic problem, and it is predominantly of the making of men. And we as men need to stand up and call it out and call for changes that need to be mandatory. That's really as I see it.
I'm sure all of you will wish, as I do, that this panel could go on for the whole entire day. But as we are coming to a close, I want to ask you to answer this question: what gives you hope for the future, specifically around male engagement in addressing women's cardiovascular health?
I mean, to me, I think the answer is that there are individuals that are now going into this field, and it is a field, and we cannot mistake this, and they are going to be both men and women. And I would also say, to answer the question of how we make change, you know, you would like to say it's out of the goodness of your heart, but actually outcomes and public reporting of outcomes, including men and women, outcomes, and these surgeons or the cardiologists that are that negative reinforcement of having money taken away, if the outcome is not as good, will make them invest more into this.
Yeah, we're coming back to economics, right? Economic argument.
Same thing. For microvascular, we advocated the CDC to recognize the disease. It took me a year and a half. I testified with my team, with the help of the industry who brought the technology in, to just convince the CDC that there is a disease called microvascular illness, which could cause heart attacks. There's a disease called INOCA, which now we see more in the literature. That gives me hope that it took a small, it's a small effort that grew bigger, it got amplified. Now the CDC released an ICD-10 code, which is an international code of diseases, which means whatever they release is going to be used all over the world. And now Syndrome X is dying out, and there is a diagnosis called INOCA, ischemia with no obstructive coronary arteries, and then MINOCA, which is a myocardial infarction. So that gives me hope that we started small, got bigger. Everyone is thinking about it. Same thing with transplant, with ejection fraction. It's growing. I see a lot of terminology that I never knew. Like there's HEF, PEF, which means heart failure with preserved ejection fraction. It's something I never studied in med school. That did not exist. That came out, 5-10 years ago? So there is hope that we are on the move. There's always, maybe not as fast as we like to, but again, we're working hard, we're doing things together, and hopefully that will move the needle even further.
The question again?
What gives you hope about male engagement in women's cardiovascular health?
What gives me hope? To be honest, I think it's not that I see a bright star coming towards us and that men are awakening to the reality that they have a role to play in this. We have to make it happen. And I think the male voice in this really needs to be heard. And I think, we're talking about women's health and women's cardiovascular health. This is not like a minority issue. Women are 52% of the world's population. It is just astounding that it is the way it is. And as I said, the problem is so systemic that we really do have to start working at the system level. And if that means introducing regulations and making equity mandatory in grant allocations, in data analysis, whatever it is, this is what really needs to happen.
Thank you, Neil. Can you please join me in thanking our panel? Amazing.